medical buying group, MedResults Network. And on behalf of myself at MedResults and our special guest speaker, Dr. Jonathan Kaplan, we thank you for joining us today. And I realize this is a little bit of a mixed audience. We have a lot of MedResults members, but for those of you who may be new to our webinars, we're delighted to have you as well. A little bit about MedResults. Our organization is the largest free aesthetic medical group purchasing organization here in the US, with nearly 3,400 aesthetic medical practice and medical spa members. We've got about 40 industry leading manufacturer and vendor partners as well. And we'll talk a little bit about one of them who's here with us today. But before we begin, I just want to let you know we do have an extensive presentation planned for you today. So I'm going to jump right into the introduction of our special guest in just a moment. But I will say quickly that for those of you who aren't familiar with the No Surprises Act, which is our topic of the day, I think the most important thing to keep in mind throughout the presentation is that this piece of legislation affects every type of medical provider. So whether you run an entirely cash pay business or you've incorporated billing services for reimbursement, you're not immune to this act. So that's why we've invited the expert in price transparency, Dr. Jonathan Kaplan, to speak with us today. So to tell you a little bit about Dr. Kaplan's background, he is a board certified plastic surgeon originally from Louisiana, and he currently runs his practice, Pacific Heights Plastic Surgery, in his hometown in San Francisco. Fun fact about Dr. Kaplan, he actually completed his fellowship at the Cleveland Clinic, where he was trained by the same team that performed the first US face transplant. And then he went on to open a successful cosmetic practice in Baton Rouge, Louisiana. During his first 6 years of practice, Dr. Kaplan actually noticed that many of his patients were coming to consultations without an understanding or appreciation for the different costs associated with plastic surgery procedures. And I think while he realized that all patients have unique needs, he also believed that by giving an estimate online, patients could have a better understanding as to whether a surgery was affordable or out of their budget. So as a direct result of that, he created a company, BuildMyHealth, which is actually an app with a price estimator that allows patients to find doctors in their area, and then also to peruse a number of different procedures so that they can get itemized estimates on those procedures. So in effect, that creates that price transparency that patients really want. So one more thing before I turn it over to Dr. Kaplan, I want to encourage everyone joining us today to participate at any time during the presentation. You'll notice on the webinar control panel, there's a chat box. And again, I encourage you to ask questions throughout the presentation. We will absolutely get to those by the end of the event. And also we have some additional information here for you today. There's a document feature where you can download a little bit more information about BuildMyHealth. And we'll also initiate an offer towards the end of the presentation, and I will draw your attention to it once we do. So with that, I hope you enjoy today's presentation, and I am going to turn it over to Dr. Jonathan Kaplan.
Thank you so much, Jamie. So happy to be here. I love being a part of MedResults Network, and very happy to be able to talk about the No Surprises Act to the audience. As you mentioned, I am the founder CEO of BuildMyHealth, a price transparency lead generation platform, and now No Surprises Act compliant. You alluded to this as far as the audience today, and I want to encourage everybody that if you feel like I'm not talking about something you think that directly applies to you, just wait, hold on. I promise I'll get to you, because we do have a lot of different aesthetic providers, some doctors or providers that are doing insurance-based services, some that are doing both, a hybrid, or they're part of a multi-specialty group. But I promise you that there's some part of this act that definitely applies to you. The thing with the No Surprises Act is that, it was passed in December of 2020 as part of a bigger COVID relief bill. And so you haven't heard a lot about it. Maybe the most you've heard about it is that it was to address people getting surprise bills in emergency situations. And it is about that, but it is about so much more. And I don't want to sound hyperbolic and say that this is the biggest act ever, but from a healthcare perspective, I feel like in my lifetime, there's been no healthcare legislation that has had as much of an effect on providers, on their daily practice, on the daily running of their business as this act does. HIPAA, yeah, sure, you have to put some forms together for a patient. That was not as big a deal as this. The Affordable Care Act, I don't think affected doctors as much as this. It certainly affected patients, but this really affects doctors and how they run their business. and the possibility of grinding their practice to a halt. So I think we have to keep in mind that this does apply to this, even though we may not want it to. And I'm going to get more into that. But and if you're thinking, oh, this is something I can like work on down the road, well, actually, this is the law of the land as of this past January 1st. So we're all non-compliant to some extent. As far as which patients it does not apply to, that's probably an easier way to start. It doesn't apply to any federal programs like Medicare or state programs like Medicaid, Indian Health Services, VA, TRICARE. It doesn't apply to them because those programs already have surprise billing protections in place. So some aspects of this law apply to doctors who and providers who are providing out-of-network care, uninsured care, self-pay, which we're going to get to, actually includes cosmetic care. But some parts apply to everybody. So let's start with the parts that apply to everybody. The public disclosure requirements. There are 2 notices that you must put at your front desk or wherever it is that patients check in or schedule appointments or schedule procedures or pay bills. Wherever that location is, you need to put up 2 public disclosures, which are the standard notice regarding the patient protections against surprise billing and the standard notice of a right to receive a good faith estimate. Even if you don't feel like these things apply to you, you have to put both of these things up on the front, by the front desk, if it's a med spa, a practice, whatever the facility is. You also have to put it on your website, specifically on the homepage of your website. You don't have to put this entire notice on the homepage of your website. You can just have a link, that's fine. If you want to, you can take a look at my website, PacificHeightsPlasticSurgery.com. And at the very bottom, if you scroll to the bottom, you'll see 2 links that go to both of these notices on a separate page. So you definitely have to have it on your website. These notices, I'm sure you're probably wondering, where can we get these notices? Just email me at this email address that you see at the bottom of the screen, drkaplan@ph-ps.com, and I'll be happy to send you a copy of both, or links to the standard notice regarding patient protections against surprise billing and the other notice that you're required to put up, the one for a good faith estimate. Now, the No Surprises Act, pretty big bill, pretty big act, lots of pages, but I think the easiest way to look at it is first just to kind of get an idea of what the overarching goal of it was. The overarching goal was to avoid sending patients surprise bills. And the way to avoid sending somebody a surprise bill, well, I think the first thing to remember is it's okay to send a patient a bill after the fact. It just can't be a surprise bill. And how do you avoid sending a surprise bill? You inform them of their cost ahead of time. So price transparency is a huge part of this act, which you don't really hear much about. But I mean, this is going to do more to make healthcare more of a marketplace than you've ever seen before, because usually people don't know the cost of their healthcare beforehand. That's changing with this act, but you haven't really heard about it. So the idea is to give people idea of their costs beforehand, so that if you do send a bill, it's not a surprise bill. And the way they implement this is they're looking at it, focusing it on 2 groups. So rather than just thinking of the No Surprises Act, think of it in these 2 groups, because it'll probably answer a lot of questions if you always focus on whether it is the patients who are using their insurance and you're trying to reduce surprise bills when those patients are using insurance, or if it's reducing surprise bills when patients are not using insurance. So if you think of it in those 2 categories, is the patient using insurance? Are they not using insurance? That will help lead you down the right path of what laws apply in that situation, because the regulations are different whether they're using insurance or not. The estimates that you have to provide are different whether they're using insurance or not. What prices you have to include, whether the provider, the hospital, the surgery center, the anesthesiologist, what prices you have to include differ based on whether you're using insurance or not. So I think that'll kind of break it down if you think of it in those 2 groups. So let's start with the idea of reducing surprise bills when using insurance and how the No Surprises Act applies in that situation. So let's say you are riding your bike down the street, you fall on your arm, you feel like you probably broke it. You have an ambulance comes and picks you up, whisks you away to the hospital, to the ER. You're seen by the ER doctor, who refers you over to the radiology department. You get an x-ray, you come back, they do see that you have a broken arm. The ER doctor splints you, sends you home to go see an orthopedic surgeon. Then after over the next several weeks to months, you start getting bills. You notice that the bill from the ER doctor, or that organization who employs the ER doctors, that bill is considered in network. It's covered. You still have to pay your part of the deductible, your out-of-pocket maximum, or your co-insurance, but for the most part, it's covered because it is considered in network. The hospital's bill the hospital that sends you a bill that includes, the X-ray that was done, the services in the ER, that's all covered. That's considered in-network. But you notice the bill from the radiologist who read your X-ray and the ambulance that brought you to the ER, they are not covered in the same way. They are considered out of network. They're not part of your in-network list on your insurance. And because they're out of network, if you have out of network benefits, your insurance will still cover it to some extent, but your deductible will be higher, your out-of-pocket maximum will be higher, your co-insurance will be higher, but maybe they cover it. But if you don't have out-of-network benefits with your particular insurance plan, because it was, you got a less expensive plan, then you have no coverage for any of those things, and you have to pay for that radiology reading out of your own pocket. You have to pay for that ambulance out of pocket. Now, with the No Surprises Act, that radiologist can no longer send you an out-of-network bill. So if they can't send you an out-of-network bill, they have to send you an in-network bill. What's the in-network rate? We'll get to that in a second. But the No Surprises Act will disallows that radiologist from being able to send you an out-of-network bill. And so that way, since it's shifted to in-network, now your insurance will help cover more of that, or you still have your cost sharing, as I mentioned. The ambulance, however, is excluded from the No Surprises Act. So you're still on the hook, and you're still going to get a surprise bill after the fact from the ground ambulance. So maybe if you have out-of-network benefits, it covers it, but they can still send you an out-of-network bill for balance billing of whatever additional services. The reason ground ambulances are excluded is because Congress, when they were writing this, and they wanted to bring ground ambulances in, they realized that they were often owned by the county or city in which they worked. And so applying these congressional laws to a city or a county was a little bit more difficult. So they said, we'll just table this. We'll come back to fight another day with ground ambulances. So for now, the ground ambulances are excluded. The thing that's frustrating about it is that not only can the ground ambulances still get out-of-network rates and get higher reimbursement for their services, but because they're owned, they're an agency of the city or county, they're also getting tax revenues. So that's not something that radiologist is going to be able to do. They can't bill out-of-network, and they're not getting additional tax revenue. So the other situation where the No Surprises Act is involved is if it's a non-emergency situation. So we've just talked about emergency situations. Let's talk about non-emergency. In a non-emergency situation, if you are, let's say you're a woman, you go to the hospital to deliver a baby, you go to an in-network hospital, you have the baby delivered by an in-network OBGYN, but the anesthesiologist that puts in your epidural is out of network. And so they could then send you an out-of-network bill. If you had out-of-network benefits, you'd have to shoulder more of the cost as part of the cost sharing. If you had no out-of-network benefits, you're on the hook for the entire anesthesia bill. So now with the No Surprises Act, if you go to a participating facility or an in-network hospital, and then there's a non-participating provider that does something, then they can no longer send you an out-of-network bill. They have to charge you the in-network rate. What is the in-network rate? We'll get to that in a second. It's a little more complicated. But that is in a non-emergency situation. You cannot bill out of network. Now, does that mean you can never bill out of network in a non-emergency situation? Luckily, there's an exception, and this applies to plastic surgeons who bill out of network for breast reconstruction. Maybe if it's an orthopedic surgeon that does a certain type of hip surgery and they do all of that out of network, they can still bill out of network for those procedures in a non-emergency situation. It's very clear, non-emergency situation, they can still bill out of network if they have consent. So they've got to get a consent form, specifically one that looks like this at the Center for Medicare and Medicaid Services. CMS created this consent that you must use for the patient to sign. And this if you read this is just the top part of the consent form, but if you read this consent form says, don't sign this form. You're going to give up all of your protections against surprise billing if you sign it. And if you sign it, you're going to get an out-of-network bill. You might have to pay more, shoulder more of the cost. You might get a balance bill. And if you sign this, then all of those bills will be legal and you will have to pay them. So you have to get the patient to sign this consent form for any out-of-network care in a non-emergency situation if you want to be able to bill them for an out-of-network service. But you can't just get them to sign the consent. That's not enough. If you want them to pay these out-of-network bills, you also have to provide them with an estimate of those potential out-of-network expenses. And this is going to be a high hurdle for a lot of practices to overcome, because you can't just say to the patient, all right, well, my out-of-network bill for this hip replacement or whatever is $20,000. That's not enough information. You've got to find out what insurance they have, whether they have out-of-network benefits or not. And then you have to find out what's their cost sharing, what's their deductible, out-of-pocket maximum coinsurance, and have they paid anything in this calendar year towards their deductible, their out-of-pocket maximum, and their coinsurance. And then you've got to do all those calculations to find out, okay, they put towards this much, and this is my bill. Insurance is going to cover that much. They have out-of-network benefits. They're going to shoulder more of the cost. This is how much they're going to have to owe. And you're going to have to give them that information for your services. So you have to get them to sign that consent and then give them very specific breakdown of the cost of what they will have to pay out of pocket after their insurance is applied. So again, a high hurdle to overcome, but I'm going to talk a little bit later about some potential solutions for that. Now, just like there's an exception to the No Surprises Act that you can bill somebody out of network in a non-emergency situation if you have consent and you provide them an estimate, well, there's also exceptions to those exceptions. There are some situations where even if you get a consent, you still can't ask for it. You still can't bill out of network. And those are essentially situations where the patient doesn't have a choice. Like the ER doctor, they don't really get to say, no, I want to choose the in-network ER doctor. So ER doctors can't bill out of network no matter what, even with consent. Anesthesiologists can't, neonatologists, radiology, lab, pathology. You can imagine you don't want to have the pathologist saying, we'd like to have you sign this consent so we can bill you out of network for this pathology reading. So that's not allowed. Assistant surgeons can't do this, can't get consent and bill out of network. Intensivists, hospitalists. Essentially, if you don't have a choice, you can't get, if the patient doesn't have a choice in your situation, then you can't get consent. So that also means that if you're like a plastic surgeon and you do breast reconstruction and you're out of network, if nobody else in that area provides that same type of breast reconstruction as an in-network provider, you're not technically allowed to provide that service as an out-of-network provider. So it gets pretty complicated. So hopefully there's other in-network providers that are doing your service so you can continue to do it out of network. Now, I talked about earlier, as far as you can't bill out of network in some situations, like an emergency situation, or if you don't get consent, you have to bill the in-network rate. What's the in-network rate? It's called the qualifying payment amount. And there are several lawsuits, and I'll give you some background first, and I'll kind of give you an upshot of what the lawsuits are saying. The background is Congress, when they wrote this law, they said that if you are not allowed to bill the out-of-network rate, you have to bill the in-network rate. How do we come up with what the in-network rate is? So they said you can look at what the insurance company's median in-network rate. That's one thing you can look at to take into account. You can look at what you've gotten reimbursed in the past as the doctor. And you can also look at how complex the case was. So if the insurance company says, well, I only want to pay you $100, and I'm saying I want to get paid $1,000, then if we can't come up with an agreement, then it would go to an independent dispute resolution process. And then they would take into account what Congress wanted, whether, how complex it was, what the median in-network rate was, and what you've been reimbursed in the past. They can take into account, the arbiter can take into account those things. But then when Congress passed this on to CMS to implement the regulations, CMS wrote the regulations and took out all those variables and said, we're just going to say the in-network rate is the median in-network rate that the insurance company decides. So basically they're allowing the insurance companies to put their finger on the scale in their own favor. And so there were multiple lawsuits saying, well, that's not what Congress intended. Congress said you could take into multiple things into account. CMS made rules that didn't go along with what Congress intended. And so the Texas Medical Association and multiple other people sued, and Texas Medical Association just recently won their lawsuit that overturned what CMS wanted to do. So no longer can you just say that the median in-network rate is what is the agreed upon rate if you have to bill in-network. So Texas Medical Association won. So now they're going to revise their regulations, and the idea is they're going to take more things into account as far as what the in-network rate should be for that particular situation. And the idea is that it'll hopefully be more favorable to the doctor, but that's still an ongoing process. But if you do have to go to the independent dispute resolution process, both groups have to pay into it, and whoever wins gets their feedback. And if you do violate the No Surprises Act by sending out-of-network bills without consent or in an emergency situation, it's a $10,000 penalty. Okay, so that was all about when people are using their insurance. Now we'll talk about reducing surprise bills when you're not using insurance. And this gets into the good faith estimate. I know people refer to the good faith estimate for any estimate that's associated with the No Surprises Act, but it's not really for all of them. So yes, if you have insurance and you have to provide the patient with an estimate, it's just an estimate based on their cost sharing with their insurance. If it's But for the good faith estimate, that really only applies to people that are don't have insurance, that are uninsured or choosing not to use their insurance or self-pay. Why would somebody choose not to use their insurance? Let's say you have to get an MRI, and it's if you submit it to your insurance, it's going to be $1,000 because you haven't met your deductible, or you can just pay them cash up front and it's $350. That's a situation where you have insurance, but you're choosing not to file a claim with your insurance company. And in that case, you would give the person a good faith estimate for that study. But the problem is that since they use the word self-pay, the understanding currently is that includes cosmetic, because cosmetic patients are paying themselves. Not the same as self-pay though. I mean, if you look at the good faith estimate, this excerpt that I have up here, it says that you have to provide a good faith estimate if people aren't enrolled in insurance or uninsured, or they're choosing not to file a claim with their insurance company. Well, an aesthetic patient isn't choosing not to file the claim with their insurance company. They can't file the claim with their insurance company because cosmetic procedures are excluded from insurance contracts or insurance policies. So this was not the intent of Congress or CMS to include aesthetics, but this is legally how people are reading it now, that because patients are paying themselves for an aesthetic procedure, they're included in the No Surprises Act, and so you have to provide them with a good faith estimate. There could be some more clarification in the future as far as maybe they don't include aesthetics, but I kind of feel like it's asking the teacher at the end of class if there's any homework. Even if there wasn't any homework, she's going to be like, or the teacher's going to be like, oh yeah, there's homework. So if you ask CMS, do we have to provide estimates and price transparency to these patients ahead of time? They're going to most certainly say yes. You still have to provide them with pricing information, even if there's no chance of a surprise bill after a cosmetic procedure, and depending on how you bill. So when it comes to the good faith estimate, what do you have to do? You have to provide an estimate within 1 business day if the procedure is scheduled within 3 days. Provide the estimate within 3 days if it's scheduled about 10 days out. But either way, whenever somebody requests the estimate, you have to provide that estimate within 3 business days. And there is a dispute resolution process for this too. But keep in mind the distinction. Again, this is why it's important to think of the No Surprises Act as insurance or not using insurance. If it's insurance, there's that dispute resolution process I was talking about, but that's between the doctor complaining to the insurance company that they didn't get paid enough. In this dispute resolution process, when people are not using insurance, that's between the patient complaining to the doctor or the provider that they got a bill after the fact that was more than $400 than what the good faith estimate showed. So that's the idea behind that, is that just if you think something's going to take longer, then overestimate. You can choose to ask the patient to pay less upfront, but let them know the potential additional cost associated with it, so that if that happens, then, and even if it's over $400, you can now send them a bill after the fact, as long as it's not a surprise bill. So if it's a surprise bill less than 400, they can't file a dispute. If it's a surprise and it's more than 400, they can file a dispute. If it's more than 400 and it is not a surprise, like you told them that was a potential cost, then they can't file a dispute for that. So getting into some more distinctions between the two types of patients, insurance versus not insurance, there are 2 different types of estimates based on the type of patient, whether they're using insurance or not. So let's start on the left. I already alluded to this before. That estimate, if a patient is going out of network, aside from getting the consent, you have to provide them with the consent of their cost sharing for your services only. You've got to have the patient's name on there, the CPT code, and you have to list other available in-network providers. You can, at least what we're doing is we're just referring them to their insurance plan. The other thing is called the advanced EOB. This is specifically with insurance, and you don't have to do it yet. I want to start off with that. It's not implemented yet because the technological plumbing for this has not been implemented. But just like an advanced EOB, an EOB, an explanation of benefits, it's what patients get after the fact, showing that, they got this procedure from this doctor at this hospital, from this anesthesiologist. This is what the insurance paid. This is what you owe. So that's an explanation of benefits after the fact. What they want to do now is that after you draw up your estimate of what the patient owes for your out-of-network service, they want you to send that estimate to the insurance company. The insurance company will take that and then determine for that particular procedure what would typically be the patient's out-of-pocket expense for the anesthesiologist or for the hospital or for the overnight stay, things like that. And then the insurance company will turn around and send that completed estimate to the patient. And that's called explanation of benefits, but it's advanced because it's before the operation. So very complex. It's not implemented yet. So for now, if you're doing out-of-network care, you have to get the consent and you have to provide the patient with their cost-sharing estimate for just your services. In contrast to the good faith estimate, if it's a patient going with cash, then you have to provide an estimate with your name, with their patient's name, your tax ID number, I'm not sure why, your NPI number, the diagnosis code. There are cosmetic diagnosis codes, a CPT code, and if it's cosmetic and there's no CPT code, then you just leave that blank. Again, another example of why they didn't intend this to apply to aesthetics. And then you have to provide the cost for each provider. So whereas out of network estimates with insurance, it was just your estimate. But for the good faith estimate, you have to provide an estimate for yourself and for whatever other entities are involved, whether it's a surgery center, an anesthesiologist, things like that. And you also have to include a disclaimer saying that if you get a bill for more than $400, you can launch a dispute. Now, something that they haven't, they're not going to enforce until 2023, but they introduced the concept now, and I would say that you can start doing this now because a lot of the people on the call today are probably already doing this. The concept is of the convening provider. Now, just a little background: the convening provider is who the patient asks for an estimate from. So if a patient's seeing me for a consultation, they're going to ask me for an estimate. Of course, I would give them a quote afterwards, but that makes me the convening provider. And then I need to go out and get estimates from the surgery center and the anesthesiologists that are helping with that particular procedure. So the way the law was written, though, is the convening provider can be the provider or the facility. And so I would argue that you, the provider, should be the convening provider. Don't outsource this to the hospital or the surgery center, because if they're putting the quotes together, I guarantee you they're going to put the wrong quote together, and it's going to affect you. So I would say be a master of your domain and you create the quote. For the cosmetic surgeons on the call right now, you're already the convening provider, because when you give a patient a quote, you're probably already giving your fee, the OR fee, and the anesthesia fee, an estimated cost. And so what you can do is just overestimate how much it may take in the OR in case it does, so that if anybody sends a bill after the fact, they're covered. But I would say you need to continue to be the convening provider to protect yourself. And you already have the spreadsheets for the OR and the anesthesia fees for the different facilities you go to. I'm going to talk about an automated way to provide that quote with those different OR and anesthesia fees in a little bit. But the point being, you're kind of already doing this. So I would say continue to be the convening provider. Now, what is the convening provider liable if any of the estimates are wrong? Well, you're only responsible for your own estimate, for your professional fees. But if the anesthesiologist sends a bill after the fact that's more than $400, that dispute can be with the anesthesiologist or with the operating room of the surgery center. So just because you're the convening provider, you're not liable. But if you continue to give bad estimates to the patients based on the OR and the anesthesia fee schedule, because you might have gotten confused on the spreadsheet you were looking at, then the OR and the anesthesia groups are going to be upset. But I still think it's worth being the convening provider and just start making sure you're using the right fee schedules that they provide you, or that they're providing you with up-to-date fee schedules. So that's a lot of heavy duty information. I understand that. And we'd be remiss to just like drop all that on you and say, okay, figure it out. But what I want to talk to you now about is some manual versus automated solutions. Now, I say manual, it's kind of what a lot of us are doing right now, that we just turn around to our office staff and say, okay, here's some more things to add to your task list every day. And I think we're getting to a tipping point where there's just too many things associated with this act to just keep adding these manual tasks onto your office staff. So what I'm going to talk about now are different pain points that you're going to encounter every single day associated with the No Surprises Act. And I'll talk about some manual options, the way you can keep doing it this way, or I'm going to talk about some automated options, some solutions, things that we use in my office. And if you see these solutions, you like them, you can reach out to me, or you can reach out to your electronic health record vendor, or your revenue cycle management vendor, or your consumer relationship management vendor. Reach out to them, see if they have any of the solutions that you're looking for to help automate implementation of the No Surprises Act. So let's start with the first pain point that you're going to experience, that you're already experiencing. You're already getting calls from people asking about price. That's not going to change. But I think it's not going to get. You're already doing that, but it's going to get worse. The reason it's going to get worse is that this is all over TikTok, that people can get good faith estimates from their doctor or their provider. And the thing is, they don't really understand that the good faith estimate is a very specific document, legal document from CMS that includes all the estimates, includes the disclaimer. And so patients are going to be calling, asking for good faith estimates. They don't really need the official good faith estimate with all the pricing and the disclaimer, but they are going to want an estimate. They're going to want some pricing information. And the way we've done this in the past, and we're all guilty of it to some extent, is that we've said, oh, we can't give you the price until you come in for a consultation, or or you go through all the pricing information and then they hang up and you don't get any contact information out of it. But my point being is that if you continue to not give people an estimate, I know not necessarily a good faith estimate, but you're not providing them with some pricing information over the phone, and you're beating around the bush and going through all these scripts and things like that, it's going to aggravate patients, and they're going to think that you're not obeying the law. They're going to think, oh, he's not giving me a good faith estimate, and they could write a bad review about you based on that. They could report you to the board, your state medical board. So again, all of those are erroneous claims that they're making, but it still is a nuisance. So you can manually send out an estimate to them, draw one up, manually, which I saw a stat that takes 1.2 hours to do that manually. Or you can try to do this in an automated fashion. And, so when people call our office, we do it in an automated way. We don't go through these scripts like I was talking about. We don't beat around the bush. We just get through the pain quickly. And after we provide them with a price, then hopefully they'll come in for a consultation. So when somebody calls our office, and even if somebody's just booking a consultation, we still want people to have pricing information before they come in. So what our office staff does, they pull up their dashboard and they click on that big blue button, start a new estimate, and they ask the patient, oh, no problem, we're happy to give you pricing right now. What's your email address? Okay, this is your email address. Oh, you don't want to give us your email address? Well, we can't send you an estimate unless we have your email address. So they give you their email address, and we are able to pull up all of our procedures in our database, and we can just add procedures that we want to that the patient's asking us. So a tummy tuck or Botox or any non-surgical service, and all of the pricing information is automatically pulled up with each procedure. And so maybe they ask for a neck lift also, and then we can add that. And then we can even be so specific to say, oh, well, secondary procedures, we provide a discount. So we can even add a discount to that. So we're doing this on the fly while the patient's on the phone. We're doing this faster than any script would allow you to do. And that shows us the price on the screen. We can confirm that that's the right price. And then we can click a button to email the patient this estimate. It's not a good faith estimate, doesn't have the disclaimer, but this has the information they want. Plus, we haven't seen them yet. And we give them an estimate. We send it to them. They get an email in their inbox with a breakdown of the pricing. And then at that point, we can say, do you want to come in for a consult? Now, the other pain point that maybe is we can just avoid them calling and asking us about pricing. We can avoid the tire shoppers, the tire kickers and the price shoppers. We can avoid them calling in the first place, and we can just shift all the pricing information to our website. So you can just put a static menu on your website. Maybe you already do. But I would argue that a static menu is a terrible idea because you're not getting anything out of it. The patients see the price and then they leave. At least when people called us, we were able to get their email address. And so I would say that you could have a price estimator on your website where you capture the patient's contact information before they get any pricing information. So what we're doing now on our website and with our company is that we're taking a page out of the credit card company's playbook, and we're shifting that responsibility to the patient. So for example, it used to be when you go to the convenience store or the grocery store or the doctor's office or whatever, you had to hand over your card to the employee because they were so specially trained and in service to run that credit card, because you weren't allowed to do that. You would never figure it out. Well, fast forward, we are doing it. We are figuring it out. The credit card companies let us put in the credit card ourselves, or we use Apple Pay or Samsung Pay. So I'm suggesting the same thing as the credit card industry. We shift this responsibility to the consumer and let them check pricing on our website, but on our terms, so that we capture a lead in the process. So if you look at our website, Pacific Heights Plastic Surgery, one of the ways we do this is with a chatbot, the other is with a price estimator, which I'll show you in a second. But the patient can take a look at our price estimator. If they have insurance, they can choose the insurance plan if it's a medically necessary procedure, but they can choose a category, choose a procedure for cosmetic procedure. So we'll say enlargement and lift of breast with silicone implants. And before they see any pricing, we ask for their email address and all their contact information, phone number, zip code, all that good stuff. And then we email them. That the system automatically emails them that estimate. So we don't have to call them and tell them what it is. So they get an email that looks just like this, that has our branding, our logo, shows a breakdown of the pricing, the estimated cost, and we see the patient's email address and phone number, and then our office staff can follow up with them if we choose. But now the patient's gotten that, and they, if they're a price shopper, they're moving on. But it didn't take any office staff's time, and we didn't have to respond to an inquiry through like the website submission form or something like that. So the patient's got the quote. Now they come in, you get to your next pain point, and it's the paperwork. If it's an insurance estimate, then you have to provide that consent form that I showed you. If it is a cash pay estimate, you have to provide them with a disclaimer, which I'll show you in a second. So you have to pull that paper out and hand it to them, with the quote and everything. And you might say, well, why don't we just take that paperwork and include it in all of our intake paperwork? Believe it or not, CMS thought of this and explicitly said you're not allowed to bundle all of the No Surprises Act paperwork, the consent form or the disclaimer. You can't bundle that in to your intake paperwork. It has to be separate so so it doesn't get lost in the shuffle, essentially. So manually, you can just pull that paperwork out of the drawer and add it to the quote, like I said, or you can automate this process also. So again, the patient has submitted an estimate on our website. When they come in for the consultation, our office staff pulls up their dashboard, and we can actually search for that specific estimate, that it was an enlargement and lift of breast with silicone implants, and then we can edit that estimate. We can change it up if something's different once we see them in consultation. But then we can also switch it over to a good faith estimate, which requires us to put in their date of birth, their address. We have to come up with the diagnosis code, even for cosmetic services. And then we can adjust the pricing or add a different procedure if they're not a candidate for what they thought. But we can quickly adjust these estimates. We don't have to start from scratch and build a new estimate when they come in. And then we can print out this estimate for them that's No Surprises Act compliant, that's got their demographic information, the diagnosis code, a CPT code if it's available, a breakdown of the price with all the convening providers. And it includes that disclaimer that says that if it's over $400, you can launch a dispute. So all of that information is automatically provided within their quote now. And then we're going to sign the quote anyway. Now they just happen to be signing a quote that's No Surprises Act compliant because it's got the disclaimer included. So a much more efficient way of handling this. So one more thing about the convening provider, that if you're the one who's like having to collect the OR and the anesthesia fees, I know right now maybe you're just looking at different spreadsheets. If you go to multiple facilities, there's multiple spreadsheets. And that's possible to make a mistake and put in the wrong anesthesia or OR fee based on the wrong facility. And so we can automate this too to avoid that problem. So whenever we're building a quote, we can choose the location where they're going. And you'll notice that if we're doing a procedure in our office, it's got a breakdown of all these fees of the OR and the anesthesia fees. But if we're doing it at another surgery center, those fees change. So if you look closely at all the fields, the numbers are changing depending on the location. So with our system, we are able to pull in that location of pricing and apply the correct pricing so that we don't make a mistake, which could happen if you're trying to look and compare with all these different spreadsheets that you're using right now. So much more efficient. And then I do want to also touch on when patients are getting insurance-based services and you have to provide them with their cost sharing. I told you earlier that I have a solution for this. So right now, manually, what the office is doing? They're calling the insurance company, waiting on hold, saying, okay, this patient has this insurance number, this is their member ID number. What are they going to owe based on what I'm charging them for their out-of-network benefits? And I'm sure that's a pain in the behind. And so many of you are doing that right now with the eligibility verification. You can automate this process. So just like I showed you on my website where we have a chat bot, we also have a price estimator where the consumer can choose the cash pay services, or they can look through all the different insurance plans we offer and they can choose their insurance plan, United PPO, and then they can choose the category. We're going to use breast reconstruction as an example. And they have maybe choose the DIEP flat breast reconstruction where they take tissue from the abdomen. It's an insurance-based service, but this doctor's out of network. And so the consumer can put in their deductible, out-of-pocket maximum, coinsurance if they know those numbers. They probably don't. But what they do know is their member ID number because it's on the card in their wallet or their purse. And they put in their name and address. And this is stuff that your office staff was doing over the phone. Now the patient can do it, and you're capturing their contact information in the process. And they can see, once we verify their email address, they can see on the screen what they've paid towards their deductible already, or their out-of-pocket maximum, or their coinsurance. All those calculations are already done for them, and they see that they owe $8,300 out of pocket for that particular procedure, and the insurance will cover the rest for that out-of-network service. And then they get an email with a breakdown of all those same pricing, and they see what their out-of-pocket cost is. Now, the thing is that this accomplishes three things. One is it gives the patient a breakdown of what their costs are, and they see what their out-of-pocket costs will be. The second thing is it gives them a more realistic understanding that, yes, they do have insurance, but they're still going to have to owe something out of pocket. Because think about it right now, and patients come in, and even though they have insurance, they don't expect to pay a copay as far as like seeing the doctor. So when they're asked to pay $40, they're incensed. They're so angry. Like, why do I have to pay $40? I've got insurance, even though they paid $300 for Botox the other day from another doctor in the same building. So the second thing this does is it gives them a realistic understanding that, okay, not only do I have to pay a $40 copay, but I have to pay $8,300 to get this procedure. So when they come in for the consultation, the third benefit is that after the consultation, they go to talk to the office manager, the business manager. That's not the first time they're hearing about this $8,300 payment they have to make. And so they're not yelling at the business manager. So giving a more realistic understanding of what the way insurance works, if they still owe something, is a very beneficial aspect of this. And when the patient comes in for the consultation, just like I showed you before, the office staff can pull up that particular estimate. So this patient submitted one for a DIEP flap, and you can update all the information as far as, being No Surprises Act compliant, as far as having the diagnosis code and their address and everything in there. And for this particular case, it's breast cancer, so you would add the breast cancer diagnosis code. But the other thing that's nice about this is that when you see the patient, you can see that, okay, maybe they don't have enough tissue from their abdomen for a DIEP where you need to take it from their butt. So you can then adjust the estimate. And then you can pull up the gap flap. That's what taking it from the butt. And because you've already got their insurance information, because they put it all online when they submitted the estimate in the first place, you can now resubmit all of this information through the real-time eligibility aspect of the platform. And now you can do that without having to call the insurance company. You can resubmit that for their for this particular procedure, and you can see what their out-of-network benefits are, or if they don't have out-of-network benefits, but you see their deductible, their co-insurance, and all that good stuff. And then you can create a quote for them that includes a breakdown of all that information so that they know what their cost sharing is. And again, it includes the MPI number, things that are required by the No Surprises Act, the diagnosis code, CPT code in this case, breakdown of what they're going to owe. And it includes that surprise billing protection form that I showed you earlier that they would have to sign anyway. Now they're signing it as part of their estimate that you've just provided to them. And so they're agreeing to take out of network rates. They know what the out of network rates are. They know what their cost sharing is. You've satisfied all the aspects of the No Surprises Act. So that's what's really beneficial about automating this process. So what we've done is we're trying to transform the way your office works to make it more efficient, because now the patients are offloading all that information, that work on your back office staff to provide those estimates. Now the consumer's doing that estimate online. And so by the time they come in, you can see them and you can give them that quote. Maybe it's the same quote that they already submitted online, or you can adjust it if you've seen them and you realize that that's not the right thing. And then you can provide them with both an estimate for an out-of-network estimate with the consent form, or a good faith estimate with that disclaimer that I showed you. One of the things about when patients come in and you need to adjust their estimates, that's great for patients like who come in for a consultation. Think about how many times you've seen a patient that wants like neck lipo, lipo 360, breast dog, inner thigh lipo. And then you provide that estimate for them with all of those procedures, and they're like, oh, that's so expensive. I only want to do the neck lipo. Well, then you have to go back and you have to delete stuff, and you have to, maybe you're using Microsoft Word or Excel. You got to delete the procedure, delete the pricing. This way of being able to add and subtract procedures automatically is so much more simple, and it's also so much more accurate, because now it's automatically subtracting out the OR and anesthesia fees. It's automatically subtracting out garments or cosmetic insurance for those procedures, and so it's less likely for you to make a mistake. So I know people are anxious about price transparency, and I think it's clear now that price transparency factors is a major part of the No Surprises Act. That I want to just tell you about some benefits, and maybe it'll lighten the blow that you're like, okay, I guess we'll go with price transparency so we can deal with this, the NSA. One of the things we did a few years ago is we wrote a paper. We did a study and got it accepted into a peer-reviewed journal, where we found that when patients come in knowing pricing information ahead of time, they're 41% more likely to book a procedure than non-price aware patients. Ostensibly, the consult's not ending in sticker shock, and you're more likely to move them from the exam room to the procedure room because they came in having a better idea what the cost was. The other thing that's beneficial about people sharing their pricing information is with our platform, when you upload procedures or pricing, you can see how your price is compared to other people within the network. So you can see all the way down to the zip code level. You can see how your breast augmentation with silicone implants compares to other providers. Also with non-surgical services, you can see if you're charging too much or too little for lip augmentation with a filler. And same thing with like a minimally invasive service like Accutite. You can see, I think this is from Southern California, this doctor can see how their prices compare to everybody else in the network. Again, to hopefully make sure you're not the least expensive. I've referred to a lot of resources, the standard notices for protection against surprise billing, the good faith estimate, the consent, the disclaimers. Those are all things that you can email me and get that information from me at drkaplan at ph-ps.com. We'll have this email up later on as well, or a different email address. Either one is good. But you can get all of that. I'll be happy to send you those templates if you're interested. So even though this has been a lot of information, I really want to end on a glass is half full note that this is a lot, but we can use this legislation, which I still think is the biggest healthcare legislation for providers, is the way as far as how it impacts us, that I think you can use this legislation as an opportunity to improve your workflow by shifting more responsibility to the patient, reducing the workload on your back office staff so they're not having to call and deal with the insurance or keep pulling up new estimates for every patient that's calling, reducing burnout. And it's basically taking the existing staff. I mean, you're already making quotes, you're already convening provider, you're already collecting the anesthesia OR fee, but we're taking those existing tasks and making them more efficient, more automated, and less likely to have mistakes. So thank you so much. Hopefully you'll follow me on social media, or me or MedResults Network. And one thing I want to point out, and Jamie's going to refer to this also, is that because we are doing this in conjunction with MedResults Network, that there is a discount that if you go to buildmybod.com/providers, that there is that you can sign up there and use promo code MRN, all caps, and you'll get a 10% discount on an annual subscription. And of course, you can email me at this email address that you see at the bottom of the screen. I am going to stop sharing now, if that's okay with you, Jamie, and let you take over, or do you want me to leave this part of the screen open?
Sure. Well, you know what? Actually, we just initiated an offer. So you'll see on your dashboard, everybody should see it. There's an offer there. There's actually a link to click straight over to the BuildMyHealth platform. And the link will take you there in case you do want to use that MRN code for a subscription or just learn a little bit more about the platform. You can click on that offer, or Dr. Kaplan has been kind enough to allow us to upload a file here. And the file is just a BuildMyHealth one-pager. It gives you a little bit more information about the automation that Dr. Kaplan had shown you during the presentation. So I'd encourage you to go ahead and download that. Dr. Kaplan, a couple things. We did get some questions throughout the presentation. There was one question, it's a scenario that was typed in from one of our guests, and I'll read out the scenario and you tell me what you think. And the scenario is such that a patient's refusing an ER, I'm assuming an ER physician or director, to repair a wound and wants them to call in a plastic surgeon. The parents say no to the ER doc and wants the surgeon to repair the wound as they're concerned about the cosmetic outcome. Do you have any comments on that?
Absolutely. So if the patient is totally stable and I know they're in an emergency room, but if they've been stabilized, maybe they're in the urgent care side of the ER, and it's clearly not an emergency, and they're mentating, they're choosing to ask them to call a plastic surgeon, then you could argue that this is not an emergency, and so then it's no longer part of the No Surprises Act in regards to a ban on billing in an emergency situation. But now if it's in a non-emergency situation, if they want to use insurance and you want to bill them out of network, you can do that as long as you get consent for that in this non-emergency situation. Or if you want to treat them as a cash patient, you can go the good faith estimate route, and then you can charge them right there in the ER, get your Square reader and charge them in the ER, swipe their card, and then give them that disclaimer, and you give them a good faith estimate showing them this is how much it's going to cost, and you know you're not going to send any surprise bills because you're getting payment up front. So if it's truly not an emergency, you can go either one of those two routes, bill them out of network with a consent form, or get payment up front, treat them like a cash pay uninsured patient, or patient choosing not to utilize their insurance, and go with the good faith estimate route. So that would be how you could do that, and you could get payment.
Perfect. No, thank you for that. A couple more questions. Does the NSA apply to in-network procedures?
It doesn't apply to in-network procedures. So the reason they came up with the NSA was to avoid surprise billing or people not getting these crazy bills after the fact. And so they just started with the two situations where that was more likely to get a surprise bill. If somebody was going out of network and they didn't know how much their insurance was going to cover, so they applied the NSA to out-of-network billing. And then they also applied it to people who didn't have any insurance or weren't using their insurance. Since they didn't really have any protections, they were going to have to end up paying for it themselves. The NSA applies to those self-pay patients. So because the surprise billing wasn't as much of an issue with in-network, because theoretically your insurance is covering it, they didn't apply the NSA to that. However, that is coming. And this is a good example of policy creep. It's just going to end up being all about price transparency. Even if they don't have a law about it, there's going to be a point where patients are going to expect to know how much they're going to owe on their own cost sharing aspect of things when it comes to even in-network services. So the NSA doesn't apply to in-network, but it's coming, and you're going to be expected to provide estimates to patients for in-network services.
Very good to know. Okay, we've got 2 more questions here. What if I'm called to the ER to sew up someone's face? Can I get them to sign a consent to bill them out of network?
You can, as long as they're with it. And what I would say is that if the ER doctor is calling you, if you're on call and it's an emergency, then you're kind of, from a EMTALA standpoint, you kind of have to go see the patient as an in-network patient if you take their insurance. But if they are with it and they've already turned down the ER doctor and they're asking for a plastic surgeon, then I think that gives you that opportunity to make that decision whether you're billing them out of network, if you are in fact out of network, or if you want to treat them as a self-pay patient and give them a good faith estimate. But it's tricky. Just keep in mind that if they're in an emergency room, if there's any kind of dispute after the fact, it's going to be very hard to say it wasn't an emergency, even though we know it may not have been an emergency. If they are physically in an emergency room, that's not going to look good on the nightly news.
Okay. And our last one is actually about your price estimator. Does the price estimator work for family medicine or direct primary care? People can purchase their monthly memberships for DPC on the price estimator. Can they do that?
Yeah, absolutely. So one of the things I didn't get into is that the price estimator for non-surgical or surgical service, you can actually purchase things through the price estimator on the website, which is embedded into your website, the provider's website. And so we also have memberships and subscriptions for Botox, for filler, but that also applies to direct primary care, that if they want to automatically be charging the patient every month for their direct primary care services, this system will automatically do it. And if their credit card doesn't work, they'll get an email telling them to update the credit card. The office staff will get an email telling them that that person's credit card didn't go through. And if they're doing like, Botox, where they're paying a little bit every month and then they come in and get Botox every 3 months, then they automatically get an emailed voucher so they know when to come in to get their Botox. So lots of emails going around to keep everybody on board of knowing what the patient's benefits are and if their cards are working or not. So yeah, absolutely works for all specialties.
Perfect. I think that just about wraps up all of our questions. I will say there was a question that multiple people asked at the very beginning of the presentation, which was, can we access the slide deck? I think everybody was pretty excited about the content contained in that. Is that something we can share?
Yeah. I'll definitely get a copy of a video of the presentation to everybody, and then that way they can skip around through everything. Not a problem.
Yep, perfect. I think that about wraps it up. So I just want to give you a big thank you, Dr. Kaplan. We appreciate all the information you shared. Certainly there was a wealth of information here, so everybody will get a copy of the recording. For those of you that are MedResults members and you'd like to take a look at BuildMyHealth platform, just remember that you do have a discount for being a member. If you're not a member, I'd certainly encourage you to join. There's no downside risk nor any fees. And again, we hope to see you on one of our next MedResults educational webinars. And if you didn't get Dr. Kaplan's email, certainly feel free to reach out to MedResults as well, and we'll be sure to put you in touch. So thank you again to all of our attendees today, and Dr. Kaplan, we will see you again soon.
Thank you so much. Appreciate it. Thanks for having me.
Take care. Bye-bye.